All right, so we're almost near the end. We're almost done with everything. After Repro is going to be this big chapter of respiratory, which is actually pretty dense and it's got a lot of interconnections with cardiovascular. But right now, we're still here in reproductive, which mostly had a dense connection with endocrine. And, we've been talking about all of that. We've been making the connections. We've been going back to endocrine for the receptors, for the connections with congenital adrenal hyperplasias. And we've done a lot of practice questions. And last time, we pretty much finished up everything that was related to pregnancy complications, including the hydatid moles, main differences between complete versus partial moles, the consequences of choriocarcinoma, which can definitely occur in any woman who delivered or the baby. All right. So it's directly related to pregnancy and it affects both the mother or the baby depending on what's happening, right? Anyone can be affected. It's not just someone who had a specific type of pregnancy or something like that. And then we, of course, discussed another topic that somehow ended up bringing us back to cardiovascular, which is hypertension in pregnancy, right? Another major issue. We looked at these medications, and I told you guys to go back and review cardiovascular pharmacology, right? Because this is a good time to go back and take a look at that. It's definitely a pretty big pharmacology section that you do want to spend good time on. So after all of this was done, right, we are now up to gynecologic tumor epidemiology, and we're going to be looking at all kinds of cancers of the vagina, right? So down here, we're going to look at cancers of the vagina, the breast, and then of course all kinds of penile pathology, and then the main cancer there being just prostate cancer. So gynecologic tumor epidemiology, this is just going to be like a basic concept of like what's most common, right? Which is kind of what makes NBME so difficult, because NBME questions are generally just going to be like very minimalistic, and then your answer comes from the concept of what is most likely the answer for that patient's demographics. Okay, male, age, female, age, etc., where they're from, what their history is like, and it's all about just knowing what's most common. So here they're telling you incidence in the U.S. endometrial cancer is the highest incidence, then ovarian, and then cervical. So cervical cancer has the lowest incidence in the US, but cervical cancer is more common worldwide due to a lack of screening or HPV vaccination. Right here in America, we have pap smears, we have HPV vaccination, so all of this preventative care has severely reduced the incidence of cervical cancer. And remember, incidence means new cases. Prognosis, of course, cervical cancer has the best prognosis, especially if it's diagnosed under age 45. Endometrial, and then ovarian. Ovarian cancer has the worst prognosis, right? Especially after age 65. So, all things kept in mind, endometrial cancer looks really problematic, right? Because it not only does it have a very high incidence, it doesn't have the best prognosis either. It's like it's in the middle, right? So it's a middle type prognosis. And CEO is a good way to memorize the prognostic factor of things. But as far as incidence is concerned, just really think of endometrial cancer for sure. One good way to remember that would just be the fact that a lot of people take many medications that have estrogen related concepts to it, mechanism to it, and then of course if you take a medication that has upregulation of estrogen activity in the endometrial area, that can cause endometrial hyperplasia, which can lead to endometrial cancer. Not many things can actually cause ovarian cancer. Ovarian cancer is only common because of the way the ovary works, right? Remember, every time you release a follicle, your ovary literally bursts like a tiny little opening has to rip open in the ovary, right? So imagine like a nice smooth egg, and then something has to kind of just like an actual egg, like the chicken's egg. Imagine that, and then something cracks through one of the parts of the egg, and then now you have to seal it again, and then every month another part is cracking open and you have to seal it again, and that's what an ovary looks like near the end. By menopause, it's been cracked open so many times from different parts that it's completely, in a sense, damaged, right? And when you keep damaging any part of your body and then you keep rebuilding it, there's a very high chance of causing cancer there. So ovarian cancer is the second highest incidence, and cervical is lowest because we have a lot of preventative care. So it's not so hard to memorize this part, and it's definitely worth knowing. And then on the bottom, we have a little question leading us up to stuff we're going to be looking at. So this one's from Amboss. And it's very common to find questions where they give you tables like this, right? So regardless of what this question is about, it's very important for you to know where you would see each one of these case scenarios, right? And of course, E is just a normal human being with no clinical scenario at all. But the others are all definitely related to some level of pathology. Our patient is a 17-year-old girl brought to the physician because her mother is concerned about her lack of appetite and poor weight gain. The patient reports that she had a 15-pound weight loss over the past 6 months because she's training for an important swim team competition. She maintains a diary of her daily calorie intake. Amenorrhea occurred at the age of 12 years, and her last menstrual period was 4 months ago. She's at the 65th percentile for height and below the 5th percentile for weight and BMI. Examination shows conjunctival pallor, which is definitely very significant. Remember, physical exam and lab results are very, very significant. Everything else is just a story, kind of there to throw you off, somewhat guide you. Which of the following sets of serum findings is most likely in this patient? All right, so with the percentile sentence, right? She's at the 65th percentile for height, below the 5th for weight and BMI. Remember, we discussed that percentiles are often given in many questions, but it's not really that significant unless the percentile is below 35 or 30, right? So the 65th percentile for height is, not significant for us. We don't really care about that part that much. But her height, right? For her weight and BMI, right, below the 5th percentile, that's obviously very, very significant, extremely significant, because she's pretty much anorexic in a sense. That's what they're telling you. So overall, what we're getting here is that it definitely could be, and this is something you would have to knock out from your differential diagnosis. It could be that she's pregnant, right, because she hasn't had her period in 4 months. But what's more likely is the fact that because of her athletic event that's coming up soon, she's just lost a lot of weight. She has no energy, and right, the examination with the conjunctival pallor, she might even be anemic. So she's so anemic and weak now that she's just not having menstruation. Okay, she's kind of messed up her own hypothalamic gonadal axis. So those are the two likely things, and of course you would order a blood test to check for her HCG production if she's possibly pregnant, but that'll probably come back negative and she won't be pregnant. So this patient, it's most likely amenorrhea because of the fact that she lost weight, which would be termed secondary amenorrhea, right? Primary amenorrhea would just be not having menstruation anymore. So now we have to look at all our answer choices A through F, of which we can definitely knock out E because everything should not be normal in her. She's definitely messed up something by not eating enough and losing all this excessive weight. So what could have gone wrong when you do something like that, right? And you have to look at all your answer choices. So would GnRH secretion increase, right? Will LH be high? Will FSH be high? Or would any of the estrogens be high? What should come to you immediately and most obviously is that estrogen will not be high. It can't be. If estrogen was high, she would technically be menstruating, right? So that puts us down to really just C, D, or F. Okay, C, D, or F. Her estrogen cannot really be high at all because then she would be menstruating. She would have that endometrial hyperplasia, which is what estrogen causes, and then eventually she would have her menstruation. Then after that, you have to remember the whole feedback aspect of things, right? What goes back and inhibits other things. And you would be able to come down to eventually just picking D, which is really easy to understand and memorize. Everything would be low. She's not making any of those guys, right? Everything is low. The answer here was D. Secondary amenorrhea, excessive concern about weight gain and nutrition, weight loss with a low BMI, and conjunctival pallor from anemia raise suspicion for a diagnosis of anorexia nervosa. Right? So now we're kind of connecting this to something we saw in psychiatry. This set of lab findings is consistent with hypogonadotropic hypogonadism. And remember, we talked about this a little earlier in reproductive path. So this means hypogonadotropic means that you're not releasing gonadotropin-releasing hormone, or LH-FSH. And hypogonadism means that your gonads are not releasing estrogen. And that's exactly what she has. So secondary amenorrhea is hypogonadotropic hypogonadism, which helps you remember answer choice D. Everything is hypo, low. This patient has anorexia nervosa, in which severe caloric restriction results in reduced pulsatile GnRH secretion from the hypothalamus. This disruption of the hypothalamic pituitary gonadal axis, right, HPG axis, causes decreased FSH and LH secretion from the pituitary gland. Right, so it all started with not making enough GnRH, then she's not making enough LH and FSH, and without either of those guys, there aren't going to be enough estrogens. So that's basically what they're telling you, right? Which leads to decreased sex hormone production by the ovaries and secondary amenorrhea. So very common thing. It can occur in any patient, really, right? Because younger girls, 17-year-old girl, younger girls are definitely known for being excessively concerned with their physical appearance, right? Especially in high school and early college. And then if they're part of a swim team or any other athletic team, it further amplifies that. So you got to be very observant of all of that from the question stem, and then of course the physical exam and her low BMI were all just very significant for all of that. Okay. Next up, so now we can jump right into vulvar pathology, right? So there's either non-neoplastic or neoplastic, and the neoplastic stuff is eventually going to get much more intense. But the non-neoplastic stuff is pretty easy. So there's only 3 that they talk about here. Obviously, there are many more things that occur in real life, but the book really only talks about these 3, and these 3 are the most common ones you'll probably see on your test. There's the Bartholin cyst and abscess, right? So due to blockage of the Bartholin gland duct causing accumulation of gland fluid, may lead to abscess secondary to obstruction and inflammation, usually in reproductive age females, associated with Neisseria gonorrhea infections, right? Bartholin glands are also known as the greater vestibular glands, which always sucks when something has 2 names. Like, that's just dumb. That's not the point of a name. But Bartholin gland cyst, so how would this really present in a question, right? So you're really just going to have possibly someone who might have had history of Neisseria gonorrhea infections, and it's just going to be a reproductive age female presenting with obstruction and inflammation, a lot of fluid from the Bartholin glands just accumulating, and nothing else, right? Remember that excluding other things really helps you figure out your diagnosis, and there really shouldn't be some kind of tumor, any kind of other like big, cyst or any renal issues, nothing like that. The Bartholin cyst is just a tiny cyst that's obstructing the Bartholin gland from actually secreting its products, and that's really it. Very low yield topic, but very easy topic. So if you do see it, you want to get it right. Lichen sclerosus and lichen simplex chronicus are a little more high yield than the Bartholin cyst. Lichen sclerosus is a thinning of epidermis with fibrosis, sclerosis of dermis, right? So a thinning of the epidermis because of the fibrosis and sclerosis of the dermis. Presents with porcelain white plaques with a red or violet border. Skin fragility with erosions can be observed, most common in postmenopausal women. Benign but slightly increased risk for squamous cell carcinoma. So how do you see this? So first of all, they give you an image. So this image B right here, right? And what you're really trying to understand here at this point is basically that this is just going to be a patient with the sclerosis part, right? You're going to see sclerosis, and there's really not supposed to be any sclerosis in the vagina at all, because it's supposed to be mostly just moist and really warm and wet, not sclerosed and fibrosed, right? That's going to also present with other things. You have to remember that if this patient is having sex, she will also tell you about pain with sex, and that's another thing that helps you further arrive at this diagnosis. The last one is lichen simplex chronicus. So this is similar, as you can tell from the name. So hyperplasia of vulvar squamous epithelium presents with leathery, thick vulvar skin with enhanced skin marking due to chronic rubbing or scratching. Benign and no risk of squamous cell carcinoma. Okay, so there's a very clear difference between the two. The leathery part is the simplex chronicus, and sclerosis is just sclerosis, right? But of course, both of these, in fact, all 3 of these are going to present with pain during sex, and you have to be very careful to hear that out from the patient's presenting history. Very significant stuff. The main difference between sclerosis and simplex chronicus mainly just being the risk for SCC. Okay, so keep that stuff in mind. But these are all the non-neoplastic ones, so these are much lower yield. One thing I do want to say though, with all the female pathologies, age is a huge differentiating factor. And we can already kind of see that here, right? Reproductive age females are going to be the females that are age 40 and below, right? Lichen sclerosus, though, with telling you that this is going to be a postmenopausal woman, this is usually going to be someone 40 or above, right? And the book told you that menopause usually occurs at age 51. But that's not, the most common thing. Really, a lot of people in America, most women usually are menopausal by age 40 because of various reasons. So keep that in mind, right? The age difference is really big, especially when we get to breast pathology. A lot of those different breast pathologies, whether they be benign or malignant, they're all easily differentiable by age. So definitely got to keep in mind the age aspect. The next half of this page talks about the neoplastic stuff, right? So vulvar carcinoma versus extramammary Paget disease, right? Paget always keeps popping up. There's going to be a Paget disease of the breast too. So vulvar carcinoma is a carcinoma from squamous epithelial lining of the vulva. It's rare, presents with leukoplakia, biopsy often required to distinguish carcinoma from other causes. HPV-related vulvar carcinoma or non-HPV vulvar carcinoma. The HPV-related one is associated with high-risk HPV types 16 and 18. The risk factors for that are going to be discussed right here on the next page, but risk factors for that, and this is something that was tested by UWorld, are multiple partners, early quitarchy, usually in reproductive age females, right? So there's a couple risk factors you have to know for HPV, and we'll get there when we see it on the next page. But non-HPV vulvar carcinoma is usually from long-standing lichen sclerosis, which is what we saw here. All right, so very straightforward connection right there. This non-neoplastic thing became neoplastic. The last thing on this one, extramammary Paget disease. So this is an intraepithelial adenocarcinoma. Carcinoma in situ, low risk of underlying carcinoma versus Paget disease of the breast, which is always associated with underlying carcinoma. Presents with pruritus, erythema, crusting, and ulcers. Okay, and you can already tell this looks really weird. And when we look at the breast Paget disease of the breast is going to be the same thing. There's going to be this like really pink purple skin. I need to tell her to stop booming right now. हाँ मैं आंटी को मना किया तो अभी झाड़ू देने के लिए बहुत आवाज हो रहा है हाँ ठीक Okay, so extramammary Paget disease. When we see the Paget disease, the breast part, that's going to be the same kind of stuff. You're going to see this kind of discoloration of the skin, right? Not this stuff per se, but you're going to see this weird discoloration of the skin around the areola, and it's going to be the same kind of thing. So every time you see this kind of weird discoloration, either here or on the breast, you immediately want to think of Paget disease, and you don't really want to waste too much time reading more of the question at that point. But yeah, crusting, right? Crusting ulcers, which is this part right here, is going to be a very easy giveaway for the extramammary Paget disease. The other half of this page talks about the imperforate hymen and vaginal tumors, and then we're going to really get into more cancerous stuff as we move on. The imperforate hymen is a very easy topic. We have a practice question down here too. Definitely nothing to overthink about with it. So imperforate hymen is a failure of hymen's central epithelial cells to degenerate at birth. Right? And this is a cartoon image showing you that. Accumulation of vaginal mucus at birth, self-resolving bulge in introitus. If untreated, it leads to primary amenorrhea, cyclic abdominal pain, hematoculpus, which is accumulation of menstrual blood in the vagina, and bulging and bluish hymenal membrane. Okay, so these are all the things that can be in the question, and the way it'll present in a question can really confuse you if you don't kind of foresee this coming or don't think of this topic. But see these images are from UWorld here on the side showing you that, right? So this is the hematoculpus. So you can see all this blood accumulating because it can't come out because the hymen is still closed, heavily closed, and then this is how it kind of looks like, right? So it's not coming out. This has to be pretty much incised and then opened up and removed for this to be resolved in a sense. Over here I wrote presents with eugonadotropic amenorrhea. Patients will have fully developed secondary sexual characteristics, so normal levels of estrogen and gonadotropins, but incomplete canalization of the vaginal plate. So this is the only case scenario where if you get a question with these kinds of answer choices, right, for that patient with an imperforate hymen, you would pick E. Everything is normal. Right? Everything is normal, but she's unable to have menstruation because the opening isn't there. Right? But she can urinate just fine. She just doesn't have the opening to actually menstruate. So all the blood is accumulating, and there's a question down here that kind of shows you how this can present. But keep in mind, this is a UWorld question, which of course, being UWorld, tells you way too much information in the clinical scenario. Not all of that needs to be given to you. So they tell you a 16-year-old girl comes to the office due to pelvic and crampy lower abdominal pain that seems to recur at the beginning of each month and resolves after a day or two. She thinks the pain began approximately 6 months ago, and it is worsening significantly each month. The patient has never had a menstrual period. She and her boyfriend have not had any kind of sexual intercourse, including digital, oral, vaginal, or anal. And then I added, this description was interesting. Why get so specific, right? They could have just stopped at saying, never had any kind of sexual intercourse. But they had to talk about digital, oral, vaginal, or anal. The patient's weight, height, and BMI are average for age and sex, and she has fully developed secondary sexual characteristics. Exam reveals a palpable mass anterior to the rectum, and beta HCG is negative. What is the most likely diagnosis? Okay, right, so the reason they talked about the digital sexual intercourse is because they basically wanted to let you know that she has an imperfect hymen, right? He can't even try having digital sex with her or sex with her in general, vaginal sex with her in general, because she doesn't have an opening for him to actually penetrate. Imperfect hymen was the answer here, and then they talk about hematoculpus. This is an obstructive lesion caused by incomplete degeneration of the central portion of the fibrous tissue band connecting the walls of the vagina. At birth, vaginal secretion stimulated by the mother's estrogen can cause mucoculpus, accumulation of mucus in the vaginal canal, which may manifest as a bulging introitus. If the condition remains undiagnosed, the mucus is reabsorbed and the child will be asymptomatic until menarche. The patient may then present with primary amenorrhea and normal secondary sexual characteristics with cyclic abdominal pelvic pain due to accumulation of menstrual blood in the vagina and uterus. Hematoculpus manifests as a vaginal bulge anterior to the rectum. Right? And that's also going to be stuff that can try to confuse you with answer choices, so I want to show you something real quick. And wow, I really thought this guy was done with his construction work, but it's been a while since I heard him doing his bullshit in the backyard. Everyone's testing today, huh? Okay, so this stuff, right? Remember we looked at this earlier in reproductive? We talked about different kinds of bulges you can have down here. So we looked at the cystocele. A prolapsed uterus was really easy. This is just the uterus coming down from where it's normally supposed to be. Then you have the cystocele and a rectocele, right? The cystocele being the bladder bulging this way, right? And this is the anterior part, an anterior bulge. Or you could have a rectocele where the rectum is bulging this way. That's a posterior bulge, a rectocele, right? These things can be in answer choices to confuse you with the vaginal pathology we just looked at. So don't get thrown off because they tell you here, right? This is an anterior bulge, but this anterior bulge is not a cystocele, right? So don't get thrown off if that's in the question choice. It is an anterior bulge, yes, but this anterior bulge is not a cystocele. This is just hematoculpus. It's all that blood accumulating inside, okay, because she cannot menstruate. The last thing on this page are some basic vaginal tumors, and this here is an actual image of what sarcoma botryoides looks like. So this is a cartoon drawing of sarcoma botryoides from Netter. So vaginal tumors: vaginal squamous cell carcinoma, clear cell adenocarcinoma, or sarcoma botryoides. The squamous cell carcinoma is usually secondary to cervical squamous cell carcinoma. Primary vaginal carcinoma is rare. Okay, so that's why we have to make sure we do cervical pap smears nonstop, because this can lead to vaginal squamous cell carcinoma, which is obviously much worse. Clear cell adenocarcinoma affects women who had exposure to diethylstilbestrol. I think that's the whole name of it. This was a medication that used to be given to patients that were pregnant. So if your mother was taking it while you were in her womb, you would have an increased risk of clear cell adenocarcinoma, right? This is very low yield now because this medication is no longer used. So if it does pop up on your test and you see DES, which they'll probably write out the whole name of the medication, you want to think of clear cell adenocarcinoma. And the easiest one over here is sarcoma botryoides. It's an embryonal rhabdomyosarcoma variant. Okay, and this is what it really looks like. Affects girls that are super young, under age 4, with spindle-shaped cells. And when we were doing NBME, there was one NBME, I can't remember which one it was, but someone put together a list of things that has spindle-shaped cells. Okay, And when they tell you spindle-shaped cells, they love throwing this at you in a question stem because it can really intimidate you and throw you off. So don't really let it get to you that much. But keep in mind that this rhabdomyosarcoma, sarcoma bichoroides of the vagina, has spindle-shaped cells that are Desmond positive, right, because it's muscle. Presents with clear, grape-like polypoid mass emerging from the vagina, as you can see in this drawing. So these are all the basic, less confusing ones that we're going to be needing to know, right? So we got the Bartholin cyst, lichen sclerosis, which has more risk of cancer, vulvar carcinoma, and Paget of the vagina, right? Extramammary Paget disease, imperforate hymen, and then a couple other things here, hematocolpus and sarcoma botryoides. Nothing really intense, just a bunch of different pathologies, but nothing immensely confusing. All right, then we move on to cervical pathology. So cervical pathology, this is where they're really going to talk about all the HPV related stuff, and they're going to relate it to the different genes that it messes up. Okay, and you get questions on this that can present with many things. I've got one practice question up here, but generally speaking, a lot of things can pop up regarding a question about HPV. So dysplasia and carcinoma in situ of the cervix. Disordered epithelial growth begins at basal layer of squamocolumnar junction, which is the transformation zone we talked about earlier in reproductive, and then extends outward. Classified as either 1, 2, or 3, where the 3 is severe irreversible dysplasia or carcinoma in situ, depending on the extent of dysplasia. So that's all pathology stuff. Associated with HPV 16 or 18, which produces both the E6 gene product and the E7 gene product, right? And you have to remember these gene products because that's the pathophysiology of how HPV causes cervical cancer. So E6 is the one that inhibits TP53, and E7 is the one that inhibits the retinoblastoma, right? And if you inhibit both of those things from doing their job, those tumor suppressors are no longer going to be able to stop you from having cervical cancer. 6 before 7, P before R is one way to memorize that, sure. But generally speaking, use whatever works for you. For me, it was, P before R is what I used when I first started studying this, but eventually it just became memorization. Let me see. So that's the genetic aspect of the pathophysiology. And then what are you going to see on histology? So I put an extra image here. This is the image labeled A is the one that first aid gave you. This blue image is the one that came from UWorld. So you're going to see something called the coilocyte, right? Coilocytes are pathognomonic of HPV infection, which means that if you see coilocytes, you know we're talking about HPV-related carcinoma in situ. May progress slowly to invasive carcinoma if left untreated. Typically asymptomatic, detected with pap smear, or presents as abnormal vaginal bleeding, often after sex. Risk factors for HPV-related carcinoma in situ of the cervix include multiple sexual partners, which is number 1, smoking, early coitarchy, which means starting sex at an early age, DES exposure, again, immunocompromised, like HIV or any transplant that might have put the patient on medications that make them immunocompromised. So on the left, the reason I put this image here too is because you have to remember that if you're ever given a histo image, it doesn't mean that it's always going to look like that on your test or wherever else you look at it. So it's very important to look up more images of it, right? Because sometimes, for example, in first aid, a lot of the histo images they ever show you are really zoomed in because they want you to see something. But on your test, it's not going to be that high of a magnification. It might be a more broad image. So you have to be ready with that. And of course, stains can change, as you could tell here, right? The blue versus the purple one. So very important to be able to actually recognize coilocytes. Over here I wrote, a coilocyte is an immature squamous cell with dense, irregularly staining cytoplasm and perinuclear clearing halo, right? You can kind of see that. It also has an enlarged pyknotic nucleus where the chromatin has condensed for apoptosis, right? So raisinoid, and they often describe it like that too. They call it a raisin-shaped nucleus. So not very confusing because there aren't really other things that look like this, so you can definitely catch that. Over here I wrote HPV is the strongest risk factor for cervical dysplasia, and if the patient is immunocompromised or immunosuppressed, then you have to screen them regularly. So let's take a look at this question up here. So this one says a 35-year-old nulliparous, mildly obese woman is diagnosed with carcinoma in situ, CIN, but carcinoma in situ basically because of CIN3. She has been sexually active for 15 years and has had 4 lifetime partners. She has been monogamous with her current partner for several months and takes oral contraceptives consistently. The patient does not use condoms and douches regularly to stay fresh. Menarche occurred at age 9, and her menses recur every 28 days and last 6 days. She had a plantar wart a few years ago, but otherwise has no medical problems. She drinks 1 to 2 glasses of wine every night, but does not use tobacco or illicit drugs. The patient's mother had breast cancer at age 42. What is the most significant factor that predisposes her to cervical abnormalities? Right? They gave you a whole list of shit here, right? All kinds of things that she does, of which many of them could be risk factors for HPV, but they want to know the most significant factor that predisposed her to cervical abnormalities. And the one thing they didn't mention was in the answer choices, and that was the correct answer, right? Is the lack of barrier contraception. They didn't mention that she uses condoms or not. They just said that she uses oral contraceptives. Remember that there's a very big difference between using condoms and oral contraceptives. Oral contraceptives, if used consistently and correctly, are only there to prevent pregnancy, whereas a barrier, like using a condom, is there for the prevention of actually passing on STIs, right? And she had a plantar wart, which is a giveaway that she definitely contracted something at some point. And now she's presenting with CIN3. So squamous cell carcinoma is preceded by CIN due to HPV 16 or 18 infection. Nulliparity, early menarche, and obesity increase the risk of endometrial cancer, but not what she has. Douching is a risk for bacterial vaginosis because it disturbs the vaginal ecosystem. We talked about that earlier too when we were looking at a couple of videos ago. We looked at a bunch of vaginosis type things right here, right? We looked at all the different bugs that can cause vaginal infections, and a couple of them mentioned douching as a thing, right? And that's because when you douch regularly to stay fresh or something, you kind of destroy the normal pH and the normal ecosystem of your vagina, which increases the risk of you getting bacterial infections, but not CIN. And then alcohol consumption and nulliparity or early menarche, obesity are not one of her many risk factors. Remember, patients get cauliflower-like condyloma acuminata with HPV 6 or 11, right? Condyloma acuminata. This is just a tiny revision because there's another condyloma thing that you have to keep in mind too, but it's not related to HPV. That other condyloma thing is related to syphilis. So condyloma acuminata versus the other one is called condyloma lata. Condyloma acuminata is the one that's for HPV, okay, and 6 and 11. But her thing is HPV 16 or 18 related CIN. All right, so there's a lot of things you have to make sure you grasp correctly. Right? In this question, especially when we come down to vaginal reproductive issues, we have tumors, cancers, cysts, and then of course all kinds of vaginal infections, right? So microbiology. So it's very important to grasp that aspect of stuff too. And of course, if none of this is treated, then you have invasive carcinoma. Often squamous cell carcinoma, Pap smear can detect cervical dysplasia before it progresses to invasive carcinoma. Diagnosed via colposcopy and biopsy. Lateral invasion can also block the ureters, leading to hydronephrosis and renal failure because urine is going to back up. Low-grade CIN has cells with nuclear atypia in the basal epithelial layer, but as it progresses, it leads to expansion of immature basal cells to the epithelial surface. And knowing the differences between low to high-grade CIN is a pathoma thing, right? That's a pathology-related topic that you have to study separately if you don't have any idea what that's related to. All right, so that's the cervix. Now moving on, we have the ovarian issues, right? So primary ovarian insufficiency, eventually leading to the bigger thing, PCOS. So primary ovarian insufficiency. This is also called premature ovarian ovarian failure, premature ovarian failure, and this is due to premature atresia of the ovarian follicles in women of reproductive age. Right, so ovarian follicles just ended up dying way too early. Most often happens for no fucking reason, right? So most often idiopathic, which means that a question stem can present with no real issues whatsoever, and then all of a sudden the answer is ovarian insufficiency. Associated with chromosomal abnormalities, especially in females that are under age 30, need karyotype screening because it's related to chromosomal abnormalities. So this can be an answer choice, right? How would you diagnose this patient's issue? Karyotype analysis. Patients present with signs of menopause after puberty, but before age 40, right? Low estrogen, and then again, remember we just did that first question to start off today, right? The whole up and down arrow stuff. So here in ovarian insufficiency, it's ovarian insufficiency, which means that's hypogonadism. If you have hypogonadism, you're going to have hypergonadotropic hypogonadism, right? So the gonadotropic stuff is working just fine. In fact, it's releasing more than usual because it's really trying to get your gonads to respond, where your gonads are not working, right? So low estrogen. So estrogen is low because the gonads are not responding to the LH. This is a hypergonadotropic hypogonadism. The anterior pituitary is signaling the ovaries, but there is no result. With low estrogen, women are at risk of osteoporosis and heart disease because they can't manage their LDL well. Right, so all of that is stuff you have to connect. Even though the book doesn't mention it and it's not really related to stuff here, once they tell you low estrogen, now you have to think of all the things related to estrogen and what happens when you don't have enough of it. Whereas other case scenarios, if you have high estrogen, you have to think of all the things that occur because of excess estrogen activity. Right, so always make sure you can make that connection and think of like that bigger picture. So what are the most common causes of anovulation? Now again, this is always related to the demographics of the patient. Age, pregnancy, sexual history, surgical history, stuff like that. Pregnancy, PCOS, obesity, HPO axis abnormalities, premature ovarian failure, hyperprolactinemia, possibly because of a pituitary adenoma, thyroid disorders, right? So we always check thyroid for pretty much every system because the thyroid hormone affects every system. Eating disorders, like we saw earlier when we started today's video, right? Anorexia nervosa, pretty much inhibiting everything. Competitive athletics, which pretty much was the second important part of that same question. Cushing syndrome, adrenal insufficiency, chromosomal abnormalities like Turner syndrome, which we've seen already. Right? These are all the common causes of anovulation. Okay, and you should probably already know all of them. There's really nothing here that's new right now. So at this point, we've already taken a look at Cushing, adrenal, chromosomal abnormalities, all of these. We've seen all of these by the time we get to reproductive, which is why I always say that even though the book is in ABCD order, reproductive and respiratory being the last two chapters actually works out really well because by this point, you've already seen everything, and now you're just learning reproductive. Functional hypothalamic amenorrhea. This is also known as exercise-induced amenorrhea. Severe caloric restriction, just like the first question we did. Increased energy expenditure and or stress lead to functional disruption of pulsatile GnRH secretion, which then of course decreases LH FSH, and then that leads to low estrogen as well. Right? So hypogonadotropic, hypogonadism. Pathogenesis includes low leptin due to low fat and high cortisol due to stress and excessive exercise, associated with eating disorders in female athlete triad. The female athlete triad is a common summary basically of low calorie availability, excessive exercise, low bone mineral density, and menstrual dysfunction. That's the triad. Right? Not eating enough, weak bones, and not menstruating. That's the female athlete triad. And this is exactly what that first question we started today's video with from Amboss was about. And then the last thing on this page, the big topic which you can get so many different kinds of questions on, PCOS, right? A very real thing that many of your patients are going to be struggling with, especially if you're going into OB-gynecology. You're going to have patients with PCOS coming in, talking to you about how to get pregnant, whether or not they can get pregnant, what they should do to maintain fertility the best they can, right? All kinds of things like that. PCOS is also known as Stein-Leventhal syndrome, which I've never seen as an answer choice, but I would leave it to NBME to put this as an answer choice. Okay, they would put this as an answer choice rather than PCOS, just to throw you off. Hyperinsulinemia or insulin resistance hypothesized to alter hypothalamic hormonal feedback response. Right, so obviously this is definitely going to be related to obesity. So because of the hyperinsulinemia, somehow that is going to mess up your hypothalamic gonadal axis, and you're going to have high LH to FSH ratio, which means your LH is going to be much higher than your FSH. You're also going to have high androgens, like testosterone, from the theca internal cells, and a decreased rate of follicular maturation because you don't have enough FSH. This leads to unruptured follicles, right? A lot of follicles that now are going to become cysts. And if they're not actually going to be real follicles, they're not going to ovulate. So you're going to have cysts and anovulation. Okay, so that's what's called polycystic. All your follicles just don't mature, and that's kind of what this image A over here is showing you. This is a common cause of decreased fertility in women. Right? Earlier we saw that the common cause of decreased fertility in men was because they're actually Klinefelter patients, right? Here we're seeing PCOS as a cause of decreased fertility in women. You're going to have enlarged bilateral cystic ovaries presenting with amenorrhea, oligomenorrhea, hirsutism, which is just facial hair growth like a man, acne, and decreased fertility. Associated with obesity, acanthosis nigricans, increased risk of endometrial cancer secondary to unopposed estrogen from repeated anovulatory cycles. Right? All of these things are things that are going to be in your question stem or part of your answer. So you have to be ready with that. The patient can present with just anovulatory cycles. They'll come up to you and tell you, oh, I haven't been getting my menstruation regularly. What should I do? And then on physical exam, you might see hirsutism. You might also note that they're obese. You might note the acanthosis nigricans, which is related to obesity as well as hyperinsulinemia or insulin resistance. And you would just order a couple of labs and then you'll know the diagnosis. And you have to start treating it. So what do you do to treat it? Cycle regulation via weight reduction. Probably the hardest part for most patients, right? It's not easy to get someone to lose weight. And really, there is no actual motivation to get, there's no universal motivation that can get someone to just lose weight. And of course, there's no magic pill either that can get someone to lose weight. But generally speaking, even though these women have a chance of not being able to get pregnant, if they don't lose their weight, it doesn't always make them lose weight. Right? They're not going to go and be like, all right, I should go lose weight. But they need to, because remember that all that excess fat they have in them is making a lot of estrone. Right? And if you make them lose weight, they're going to have decreased peripheral estrone formation, which is helpful. You don't want all that excess estrogen being made. All right? That unopposed estrogen is the reason they have an increased risk of endometrial cancer. Right? So there's a risk of cancer, there's a chance of not getting pregnant, but they still won't go lose weight. So you can't just tell them, go lose weight, right? That's something you have to remember. It can be in your answer choices, but that's not the best thing to tell a patient because it doesn't mean they're going to go do it. You definitely want to put them on oral contraceptives because this is going to prevent the endometrial hyperplasia due to unopposed estrogen. And then you can use these other medications. Now, the book doesn't really go into how they can use it. And we're going to talk about these medications again, of course, when we get to pharmacology, but it's going to be a very broad discussion. So let's take a look a little bit about stuff I wrote here to get a better understanding of how all this comes together to help a patient. So I wrote here for PCOS patients who wish to become pregnant, and obviously that's going to be like majority of your PCOS patients. Clomiphene is a selective estrogen receptor modulator, which is called a SERM, S-E-R-M, that prevents negative feedback inhibition on the hypothalamus and pituitary by circulating estrogen, which basically means that all that excess estrogen is not going to go back and inhibit you from making more FSH and LH. Okay, so now you can make more FSH and LH, and that can stimulate ovulation. Right, so you have to keep in mind how that's working because this medication does get tested. I would say it's pretty relatively high yield, mostly because PCOS is high yield, and you have to know the general mechanism. So it inhibits estrogen's feedback on your hypothalamus, okay? Now your hypothalamus doesn't care how much estrogen this patient has. You will be releasing FSH and LH, and that's very important. Now that you have more FSH, significantly, we know our patient is already going to have high LH, but we need the patient to release more FSH, right, to actually stimulate the follicles. Without FSH, follicle stimulating hormone, without FSH, you end up having unruptured follicles, which then end up just becoming cysts. Clomiphene is going to increase the amount of FSH and LH that this patient is releasing, and it's that FSH with the LH surge, of course, that's going to allow stimulation of ovulation. And of course, ovulation is how you get pregnant. At the bottom, I have this extra note from Amboss, which talks about a couple other things that you really need to know, and it really puts everything into good perspective. So I'm going to read that too because it's very important for the total understanding of PCOS. So Amboss pretty much explained that PCOS is characterized by hyperinsulinemia due to peripheral insulin resistance and or increased LH secretion by the anterior pituitary. Right? This kind of notation often confuses people, especially if you're not a math person at all and you don't know how ratios work. Right? This is telling you there's a high LH to FSH ratio, which means that LH is super high, FSH is super low. Right? So this is a different way to phrase this, and I'm reading it out for anyone else that might have had some confusion there. LH and insulin stimulate the theca cells in the ovary to produce androgens, which can cause symptoms such as androgenic alopecia, hirsutism, or acne. Right? And by androgens, we're basically saying testosterone. The androgens are converted into estrogens by aromatase in the adipose tissue. Thus, hyperinsulinemia increases androgen production from theca cells and estrogen conversion from granulosa cells, and increased androgen levels inhibit the production of sex hormone binding globulin in the liver, which further increases circulating estrogen levels. Right? Without the SHBG, you're not going to bind up all the estrogen and androgens and make them inactive. So this is all part of the pathophysiology. Very important to understand that. Step 1, NBME, everyone, UWorld, these guys love testing about binding globulins, right? This is the leading topic in thyroid binding globulin too. Big topic there. So you have to be understanding of that aspect. So the hyperinsulinemia is the root cause of issues in PCOS. All that insulin is making you have high amounts of androgens and decreasing sex hormone binding globulin formation, which is also increasing your androgen levels. Androgens from the ovary and estrogen from adipose tissue decrease the production of FSH via negative feedback. Consequently, an arrest in antral follicle development occurs, and the granulosa cells, which normally produce estrogen, do not develop adequately. The lack of follicular development results in anovulatory cycles because there is no corpus luteum and no progesterone production. And remember, the most significant thing to test for to see if ovulation has occurred was to see an increase in progesterone. Right? And we're not going to have that here. So no estrogen, no progesterone production, in which the endometrium continuously proliferates under the effect of estrogen from adipose tissue. The bleeding that occurs in PCOS is not true menstrual bleeding, which is caused by progesterone withdrawal at the end of the menstrual cycle, but it's actually anovulatory bleeding, in which partial shedding of the hyperplastic endometrium occurs intermittently at irregular levels, irregular intervals, because estrogen cannot maintain the proliferating endometrium. So what does that mean? Basically, people with PCOS, women with PCOS will have spotting. They're going to have random bleeding, right? And it's not their actual menstrual cycle or anything like that. They just randomly started bleeding out of cycle because the estrogen is not progesterone. Progesterone is progestation. It maintains the proliferating endometrium, right? That thickened endometrium with spiral arteries and all of that. Progesterone is there to maintain that. These patients don't have progesterone because they don't have FSH and all of that stuff. So estrogen alone is unable to maintain it. And eventually, that endometrium starts to die and slow off. Right? But it's not all of it coming out. So it's not an actual menstruation. It's just dying. It's an anovulatory bleeding. And that's what they're talking about here. Anovulatory bleeding at irregular intervals. In patients with anovulatory cycles, the administration of progesterone would result in differentiation and maintenance of the endometrium, and subsequent withdrawal of progesterone would cause withdrawal bleeding, which is known as the progestin challenge test. And that's something that can be in your question, right? They can display a question where a patient came in with this kind of physical habitus, these kinds of physical exam, and these kinds of complaints as given in the first aid. And then the doctor might have been like, all right, let me give this patient progesterone for 10 days, and then we take away the progesterone and see what happens. And what's going to happen is they're going to have an actual full-blown menstruation, right? So giving progesterone is basically, in a sense, a form of treatment for patients with PCOS. Progesterone is progestation. It'll help them get pregnant. And the hormonal imbalance, the basic thing you have to memorize, right? Insulin, LH, and estrogen are going to be high. Sex hormone binding globulin, FSH, and progesterone are going to be low. Right? Those are the imbalances in PCOS. Very high yield topic, very big topic. You want to make sure you grab it correctly. And as usual, be able to talk about the topic as well as its treatment, management, etc., pathophysiology, all of that, without looking at the book. Okay, so hopefully this has helped understand how to deal with any patient that comes up to you saying they have PCOS, and how to even identify PCOS, and then, you know, make sure you really get the entire story here, because this topic can present in any way, right? They also tell you to give spironolactone and finasteride. Finasteride, of course, because this is going to inhibit the formation of more DHT, which will help them with their the androgenic symptoms they're showing, like the hirsutism and all of that. Flutamide, same thing again, right? So if you've never seen these medications before, or if you don't understand how they're related to decreasing androgenic activity, just go back and look at them again, because we've already talked about spironolactone when we did renal right before this. We've talked about finasteride many times as a form of treatment for male pattern balding as well as BPH, and then there's flutamide for that same kind of stuff as well. All right, so we'll stop here for now, and then in the next video we'll go into ovarian neoplasms.